Everyone. Welcome to the Happy Flosser podcast. My name is Billy Luntz. I am your host, and I'm here to talk to you about all things dental hygiene to support you on your journey through the dental hygiene program. Welcome. So glad to have you. In today's episode, we are going to be discussing radiographic interpretation of the periodontium. And this is a really important step in the assessment process. When you are first learning about radiology, your concerns are mostly focused on technique, but it's also important for you to develop the strategies on becoming really good at interpretation. What do the components of the periodontium look like? And what is the overall periodontal health status of our patient? The radiographic interpretation gives us a historical perspective of the patient's current status. We're looking at that cortical bone, the outer surface of the bone that's closely packed together, right? This is very dense on the mandible, so it will look different than on the maxilla. And the cortical bone is used to evaluate that interdental alveolar crest. And we know that in health, that appears as a thin, white line called the lamina dura. Now, the cancellous bone is less radiopaque than the cortical bone. It's lace-like in appearance, and that fills the interior portion of the alveolar process. Remember, it's important when you're first learning about radiographic interpretation to understand what things appear more radiolucent and what things appear more radiopaque. And that depends on the penetration of the X-ray beam. And you will learn that when you take radiology. The more mineralized components of the periodontium will have a light gray or white appearance on a radiograph, things like the enamel, the dentin, and the restorations. The things that have a more radiolucent appearance to them are things like the periodontium, the gingiva, the periodontal ligament. These things are less dense on a radiographic image, so it's important for you to know what the normal limits are of those items. So the alveolar crest in health, we look at the level of the alveolar bone, and the alveolar bone in a healthy patient should be about 2 millimeters apical to the CEJ. And this is one indicator that should be evaluated and noted when you are evaluating your patient. And then what is the contour of the alveolar bone? What is the horizontal contour and the vertical contour? So the horizontal contour shows us the crest of the adjacent teeth being at the same level. And when we have horizontal bone loss, which is the most common component of bone loss, the surface of the interdental crestal bone that's covered by a thin layer of cortical bone will be lower than about 2 millimeters apical to the CEJ, but it will still be parallel in its consistency. When you have vertical angulation to that crestal contour, the crest will have an angular contour on adjacent teeth if the teeth are erupted differently or tilted. And so sometimes this is still considered normal or within the normal range. If there's a parallel line drawn between the two teeth, the CEJs are still 2 millimeters above that level of the bone. So you want to make sure that you've looked at this component in the interproximal areas between the teeth to make sure that there's no indication of disease. So in that healthy patient, the crest will have an angular contour for vertical angulation, but it will still have a parallel line drawn between the crest and the CEJ for that patient. When you have true angular vertical bone loss, which is less common than horizontal bone loss, the bone is lost at an angulation, and there'll be a triangle radiolucent appearance where that periodontal ligament fiber ends up at the CEJ line. The base of the pocket would be apical to that alveolar crest in a patient who has true vertical bone loss. Now, thinking about the periodontal ligament space, and that's the space located between the tooth root and the lamina dura. And remember that periodontal ligament is attached at the cementum and the alveolar bone by way of Sharpie's fibers. So the periodontal ligament attaches the tooth root to the socket wall, and that appears radio-opaque on a radiograph. Now, the appearance of what that periodontal ligament fiber looks like can be different if there is disease present, and that should be noted when you are doing your radiographic interpretation. One of the things that we have you look at when you're first learning radiographic interpretation is triangulation, which is really hard for students to depict on a radiograph because it's a very trained eye that can see very early stages of vertical bone loss on a radiograph. Now, good quality radiographs are the first step in providing the opportunity for you to evaluate and detect disease at its earliest state. There are some limitations to radiographs, but the first thing is to create a quality image so that you can detect this horizontal or vertical bone loss. So proper imaging is the first step. So some of the limitations to radiographs is that they don't show mobility, and it is a two-dimensional image of a three-dimensional structure. There are limitations, although we are making lots of progress with our 3D imaging, there's limitations in the information that radiographics provide. It's mostly just evaluating those hard structures. So, for example, you can't see the attached gingiva on a radiographic image. It also doesn't reveal the important components of the periodontium as an indication of some of the other contributing factors to early diagnosis of periodontal disease. It certainly doesn't indicate the presence of a periodontal pocket. And you also can't see early crestal bone destruction that's going on in those early furcation areas. You also would not know specifically about mobility or defects, although some root concavities that are significant and severe and some mobility issues do show up on radiographic images. Those early detectors is what I'm talking about. So thinking about some of the benefits of the radiographs in periodontal evaluation is that some conditions can be seen early. Early bone changes, like I said, that horizontal or vertical bone loss, some of the alveolar bone loss in those furcation areas, you can detect that first on a radiograph, depending on the image. Some bone defects or significant root concavities can certainly be detected on a radiograph. The other thing that you can notice on a radiograph is that crown to root ratio. If there has been bone loss, it will help you determine the crown to root ratio for the stability factor of that particular tooth. And then the radiographs also help us with the bone loss that can be evident around our implants. So some of the early bone changes that we see. Oh, and you can see calculus on a radiograph. That's probably one of our fun things that we look for. If we can see that calculus instead of always just having to find and feel the calculus. And I know as a student, for you guys, sometimes when you're able to see the calculus on the radiograph, it gives you that confidence to then go in and find and feel it and say, "Oh yes, I can definitely feel that calculus." So some of the early bone changes are fuzziness of the crestal bone and early detection of the evaluation of that horizontal bone loss, drawing that parallel line, using your instrument to kind of see where that horizontal line would go between the CEJ to see if you can detect some early bone loss. The vertical bone loss, that destruction of the interproximal crestal bone, creating that acute angle, you want to see if you can find that at the earliest stage. So you're looking for that triangulation. And then the furcation alveolar bone loss, that's that loss of the angular bone in the furcation regions. And you'll see that as a radiolucent triangle in that region. And usually, if you can see it on a radiograph, it's actually more significant clinically when you get in there. So you want to also keep in mind your root trunk lengths. So use everything that you learned in oral anatomy and connect the dots between your oral anatomy and your periodontal charting to detect those early furcation areas. Bony defects, as I said, are really difficult to see on a radiograph, but sometimes, especially those maxillary first premolars on the mesial or the mandibular first molars on the mesial, sometimes those mesial root concavities are very significant for some of our patients, and those will show up on your radiographs, which is really, really helpful. And then with the peri-implant bone loss, the bone loss on an implant is a major sign of peri-implantitis, and the radiograph will help reveal the bone that is remaining around that implant, not necessarily bone lost, right? Because we want to know that our starting point. So the bone loss percentage needs to be estimated based on where it is expected to be for that implant. And then speaking of bone loss percentage, if you are looking at the horizontal bone loss on a full mouth series of x-rays and you just say that the bone loss is generalized, but you do not document an indication of percentage, you're really not telling the true story, or the next clinician who will be seeing that patient, really the definite assessment of that radiographic interpretation that you've done. So if there is generalized horizontal bone loss, be sure that you note a percentage of that generalized horizontal bone loss when you note it in the chart. And then the crown to root ratio is an indication of the stability for prosthesis and the susceptibility of disease for that particular tooth. So if you have a patient who has already lost some teeth due to periodontal disease or infection, and they're looking into some kind of prosthetic, it's really important to evaluate the crown to root ratio to determine the stability of the remaining dentition to accept and support a prosthetic. And then the other piece is that if the roots of the teeth are shorter and the crown to root ratio is not, if it's abnormal, where there's not enough bone supporting the root of that tooth and there's an abnormal crown to root ratio, the susceptibility of that tooth being lost due to periodontal disease goes way up. So that's a significant finding for you to note when you are doing your radiographic interpretation. Radiographic interpretation can be really hard when you're first doing it, and you end up spending so much time looking at each individual image. I promise you that just like everything else in dental hygiene, as you do it, your skills will develop and you will be able to look at an entire full mouth series and do a complete and comprehensive radiographic interpretation in just a short amount of time. The key is to sticking with the details early on so that you can have a trained eye to diagnose those radiographs and really help do a comprehensive evaluation to support the doctor when the doctor comes in and the two of you co-diagnose that patient with their periodontal disease or their healthy teeth. So keep that in mind. I didn't touch on caries detection here. This was just radiographic interpretation for periodontal assessment. I'll probably do an episode in the future on that. I hope everybody's having a great semester and you're doing well. Hang in there. There's lots of things to learn as a dental hygiene student. So keep on listening and please send me messages if there's content that you need me to cover. I'd be happy to do so. Good luck, everyone.